Hello, good evening. Welcome you all to the classroom. This is COVID pandemic, and we have to deal with medical emergencies during this pandemic, and we need to be prepared for that. There are a lot of informations and misinformations about dealing with COVID, and we've been loaded with a lot of such informations. Today, we'll be discussing practically what need to be done when such a patient comes to our emergency room or to the operation theater or to the ICU. What are the precautions we need to follow? What are the precautions we need to take to make our patients safe, as well as to maintain the safety of the healthcare providers? So for today's class, I'll welcome our esteemed panelists, Dr. Subramaniyan Swaminathan. Dr. Subra, he is a infectious disease specialist from Chennai. Dr. Sanjith is there with us. He is from Mumbai. Hi, Dr. Sanjith.
Hi.
And Dr. Ajay joining us from Thiruvananthapuram. Dr. Rahul joining from Delhi.
Mumbai. Now I'm in Mumbai.
Mumbai. Dr. Prasanna from Puducherry. Hello, Dr. Prasanna. How are you?
Hi.
Dr. Nitin is there. He's from Hyderabad.
Hello.
And Dr. Manish. He's from Delhi. Yeah. So, in dealing with medical emergencies in today's time,
so take him in the suspect area. Activate.
We have to suspect COVID in all the patients. On the other hand, if we suspect COVID in all the patients, then we'll be overreacting and we'll be overutilizing our PPEs. So that's also not a very great idea. So with this in mind, we'll go to a first scenario. In most of the hospitals, almost all the hospitals, even before the patient enters the emergency room, we are screening all the patients for the possible symptoms of COVID, namely the fever, shortness of breath, breathlessness, and cough. And of course, a travel history. Nowadays, even without travel history, if these symptoms are there, then these patients are isolated from the clean area or the clean patients, and they are dealt with separately in order to protect the healthcare providers as well as other patients. But if the patients are asymptomatic, then they go to the clean area and clean ER. Now that the patients are asymptomatic, can we be relaxed saying that we can handle the patient with usual precautions? Or because it is COVID and there are data which show that, especially in Iceland, when they screen, there are about 50% of them were asymptomatic without symptoms. Do they really pose a risk to the healthcare professionals as well as to other patients? So to answer this question, I'll just go to Dr. Subra. Subra, how to deal with these asymptomatic patients? They may present for other emergent conditions, maybe a stroke or maybe a status epilepticus. They're asymptomatic for COVID. And the data are a bit different. From China, they say that asymptomatic patients are very less, but the Iceland data is showing that more than 50% of them could be asymptomatic. Now, how much risk they pose for the healthcare professionals? Should we treat all the patients as COVID and use the maximal isolation and personal protective equipments, or a routine personal protective equipment with a surgical mask and the routine way of handling is enough in these patients, or we should not overreact in an asymptomatic patient? Subra.
If you thought that question was long, the answer is going to be even longer. So first, my apologies. I think it's a very complicated issue. I'm sorry, it's just the way it is. It's a very complicated issue. I'll try and simplify it into various parts of it. Okay. You mentioned that 50% are asymptomatic from the Iceland data. Actually, even from China, once they started doing sero testing, IgG, IgM antibody testing, they noticed that quite a few of the people who are positive by IgG and IgM never reported history of COVID. So we know that there's a significant number of people who have a very, very mild or almost an asymptomatic illness. But here's the point. Remember, the amount that you shed is usually proportional to the severity of the illness. So somebody who has a severe lower respiratory tract infection is going to be shedding far more virus than somebody who has a very mild disease. So that's a good thing, because if you're sick and you have a lot of viremia, you're going to be also showing it. So you're unlikely to have a patient who has a heck of a lot of virus being shed and doesn't have any symptoms. That's not necessarily a perfect situation, but at least that's a little comforting. Now, what about other patients who come in asymptomatic? In the early phase, like where we are in right now, where we have only pockets and we have clear history of transmission, as long as they are not in those pockets, we don't have to be too worried right now. But obviously, this is going to change. And as it changes, our protocols have to change. The third thing is, this is a very useful piece of information. There have been reports from Hong Kong and from Singapore where patients have been inadvertently ventilated in an open area, right? Where the healthcare providers were not aware that the patient had COVID. And these healthcare providers were only wearing a simple triple layer mask, and none of them, including the nurses who took care of the patient, developed COVID. They attribute this to two things. One, their mask hygiene or their mask discipline, in that they never let the mask go down from the nose bridge at any point of time as long as they were on service. And second, their insanely high rates of hand hygiene. So the good news is, even if you have inadvertent exposure, if your triple layer mask is absolutely bang on and used correctly, and if you do very good hand hygiene, you're probably safe. Yes, an N95 respirator is good when you have aerosol generating procedures, but it's not always feasible. So here's the point. Obviously, the surgical part of it also becomes an issue. As far as outpatient management, I have, on behalf of my society, already put out a document in the public domain about how to make your outpatient COVID safe. So there are guidelines on this, on how you should do, what you should do, what you shouldn't do, and things like that. I would strongly suggest people to go through that to make sure that your outpatient is as safe as possible, especially if you're having a standalone outpatient. But the surgical part of it becomes even more tricky, because if you have to intubate them, ventilate them, and take care of it, it's going to be a little more tricky. So non-GA procedures are probably a little safer, but then majority of things cannot be done without GA. So if you have to do GA, at least wear an N95 mask during the time of intubation and a face shield. You can make your own face shields with overhead projector sheets, which you can just tie around you. And these are simple things which you can easily do. And that will reduce the amount of spray coming onto you. And as long as you're not doing a laparoscopy or any kind of insufflation, the risk is actually quite low. The risk is actually very high for people who do transsphenoidal surgeries, ENT surgeries, and dental procedures. So I would give a shout out to our neurosurgical colleagues and the neuroanesthesia colleagues to be especially careful when you have transsphenoidal surgeries, because there have been very bad issues related to inadvertent transsphenoidal surgeries being done on patients who are not known to have COVID and then causing unnecessary trouble. So that is a specific area of risk. But if you're having to do a craniotomy, the risk is fairly low. As long as the patient is asymptomatic, it's the intubation which is tricky. So the intubation has to be done with an N95 mask. And after that, if you have scavenging systems, that will also add a layer of safety for you.
Okay, that's super. I'll come to the operation theater work later on. But now we are in the emergency. The patients are asymptomatic and we have to deal with their airway, breathing, circulation, maybe resuscitation. So we do not know which patient has a history. You already said that the Singapore experience where patients are the healthcare providers were inadvertently exposed to COVID positive patients, but still none of them developed COVID because of the high standard of hand hygiene and other measures which were done. And there were other reports, some anecdotal reports from Dubai also, that they have intubated the patients with a normal surgical mask, but even aerosolized generating procedure has been done, but nothing has happened to all the healthcare providers. But having said that, in this scenario, in the current scenario I'm talking about, even if you assume that there is no community spread, when a patient comes to the ER, we literally have less time to ask a detailed history. Maybe when we do everything, then later on some relative will come and say that he just traveled 1 week back and he had some cough fever day before yesterday, and today he's okay, and things like that. So should you assume that all the patients can be potentially COVID positive, at least in the emergency room, in the front line, when not much history is available and we can't do anything about it? So all the healthcare providers should be using maximal barrier precautions, including N95 and face shield or goggles, or on a case-to-case basis. Only if aerosol generating procedures are done, then we can use N95, and rest of the healthcare providers who are standing away, maybe 2 meter, 3 meter away from the patient, they can very well be protected with a surgical mask. I'll just go to Dr. Sanjith and I'll get his opinion and how comfortable he is with only surgical mask in handling the ER patient for non-aerosol generating procedures. And then we will come to you, Subra. Yeah, Dr. Sanjith.
All right. See, I presently don't believe that there is no community spread because I am now dealing with a big group of patients in my hospital. I have around 18 patients of COVID. And when we look at it as to from where they're coming from pockets, and they're coming from various pockets. That's why if you see the news, we've sealed Bombay at various places. So it is in the community, and we have patients who are old, debilitated at home, who have no travel history. Their children have no travel history, and they come to us, and we find out that is COVID. So at this moment, I don't think it is wise enough to think of surgical mask and just goggle and sit in front of the ER. That's foolishness and reckless behavior, I feel, as of now. I do understand theoretically it makes a lot of sense, but I don't think that is right, because we've had many instances of patients coming in, and this is the 10th day that we are taking in patients. So we've had many instances where we don't understand whether this patient is COVID positive. So we are suspecting each and every patient that comes in with any kind of illness. It need not be fever, it need not be cough, it can be any one of those. These patients, the common symptom, fever, cough, and breath is very, very common. So every patient that comes in, we are dealing with them with a needle of suspicion, and all of these patients, we are taking history with full gear. It is not advisable as of now to lose even a single person to quarantine. Please understand, even a small medium risk exposure, when we call medium risk exposure, means the person is not wearing a mask and I am wearing a mask. That's medium risk exposure. And if there's something like that occurs and we are close contact to each other, this kind of people have to be quarantined. I have to be quarantined for 14 days. I can't afford that. I can't afford my doctors to go on quarantine for 14 days. Because as you rightly said, Subra put it up, and you also put it up, that the asymptomatic carriers are so much. And we've noticed this, that our patients, our doctors are also getting COVID-19 positive. So I don't think it's easy enough to do this. I mean, it's nice to talk in a conference that, this is enough, but no, it's really not enough, because we are in a situation where it's blowing out of proportion. Right now, I'm having a patient coming in with CKD. Now it's just CKD. I know CKD and breathlessness. Will you say that this is COVID? You can't. We did a CT. We have patchy consolidations all around. I have just in the minute to send that patient to the suspect COVID ICU. So I don't expect CKD patients having patchy consolidation. If I would have kept my ER without anything there, I would be in a tight situation here. So this patient has now gone from the ER at this moment, from here to the CT. CT is getting sanitized, and we are taking him into our ICU, in the suspect COVID ICU.
Okay, I'll just go back to Dr. Subra. Dr. Subra, like Dr. Sanjith told, most of the doctors are concerned, even though the government and the other agencies say there is no community spread. Each and every patient, when they encounter, especially in the emergency as a first responder, they're a bit concerned. And even for non-aerosol generating procedures, invariably all the staff and others, they demand a N95 mask and the proper gear to deal with the patient. Is that okay, or we are overreacting and we are going to irrationally use the PPEs? So how to approach this scenario?
No, I think his concern is right. See, the problem is everybody is giving guidelines for India as a whole. We are a subcontinent all by ourselves. Our rates are different in different parts of the country, and our transmission is also very, very different. See, in Bombay, they already started seeing patients from Dharavi getting it. And once it gets into the area of Dharavi, it's just a forest fire. There is no way for them to distinguish who's got it and who doesn't have it. So there is a genuine concern, and it's a problem. There are small pockets like that in India where the transmission is far more intense, and really it's going to be very, very difficult for them to make a distinction. And he's right. In those kind of settings, you have to assume that every patient is possibly COVID and take appropriate precautions, and then release the patient if you are really sure that the patient is not COVID. So that's the right approach. I agree with that. I'm sorry, my comment was basically based on the fact that in Chennai, we have very little local transmission. Most of the cases in Tamil Nadu have been outside Chennai. So I suppose a lot of it was because of my own local prejudices. But yes, you'd have to look at your own particular situation. But going forward, I think some parts of it I would definitely agree with. I think your ER has to be ready all the time. You can't have a situation where a patient comes in and then you have to scramble for PP. That would be a disaster. So you have to make your ER COVID ready. And to me, every patient who comes into the ER has to be potentially triaged as a possible COVID. Now, for that, you need to skeletonize your ER in making sure that you handle as few emergencies as possible. The good news is the number of patients coming into the hospital are coming down exponentially. That's, in a way, good, because at least we don't have to stretch our resources for all kinds of things. And the ER, there has to be one consultant in the ER who's fully donned and ready with all the preventive gear, so that any patient who comes in, the patient is triaged immediately. If the airway needs to be secured, that person gets the airway in along with the nurse who is ready and fully donned during the shift. And after that, you take a call. Does this person have a possibility of COVID? Is there something I need to do extra or not? Those kind of decisions come in later on. But I think for every ER to be combat ready, at least the large hospitals, is inevitable. You have to be ready as a COVID positive patient coming in and treat everybody as a possible COVID. The idea is that we want to limit the amount of PP which is being used, because my concern is we are going to go the way of what US and UK and everybody else is going, where, if you look at the CDC guidelines, they say wear an N95 for everything. And our own government has been very, very generous about it. They want CSST to wear N95. They want to wear laundry to wear N95. They want to put an N95 to everybody, including the dog on campus. That's not possible. But we have to wear the N95 for appropriate precautions. So I think we need to have the ER, one doctor and one nurse, and a group appropriate for ventilation, for intubation and airway securing all the time, 24 hours a day, ready. We can't be scrambling after the patient comes in. That would be a disaster. And that is something we have to start doing right now. And once we do that, then the ER attending can take a call. Could this be COVID? If he is not sure, you assume it's COVID. And here's the other thing that you can do. Taking the patient to the CTU on a ventilator could possibly be very dangerous. If the patient's underlying lung does not have any major disease, young, healthy person, whatnot, a lung ultrasound would be a preferable test. So, in fact, we are now trying to push the ultrasound into the triaging area, because the lung ultrasound, lots of people are reporting it to be a very good, simple point of care triaging test to be able to tell us whether it could be COVID. Not 100% perfect, but no test is. So, as an alternative to CT scan, HRCT, a lung ultrasound could be considered if you have the resources to do this. If you're not, if your radiologists are not comfortable with it, or if they're not sure, a CT would be just as fine.
And then when we are talking about lung ultrasound, one of our viewers, he was pitching in for rapid antibody-based testing in all ER patients. So how will that work out, Dr. Subra? Yeah.
I think that will start happening, but here's the problem. It's going to take at least 5 to 7 days for an IgM to start becoming positive. And when you look at the performance characteristics of all these antibody-based tests, they're not 100% perfect. They're pretty good. They're about 90 to 95% sensitive, and maybe a little more sensitive and a little less specific. You have a few more false positives and not so much false negatives, but you have false negatives as well, small numbers. So also remember that the timing, if it is very early in the patient's illness, the patient may not have mounted an antibody response. So that's not perfect either. It's still a pretty decent test. Ideally speaking, antibody tests should be for population-based screening, where you want to see the density of infection happening. For clinical diagnosis, it's like if you had a dengue test without the NS1, you only have IgG, IgM. You will know. It's only after 5 to 7 days of onset of fever will you have a positive IgG or IgM. So think of it that way. So you will understand that the antibody test, you don't have an antigen in that. It's only an antibody. Therefore, you can miss a small window of infection. So it's not perfect. It's still a nice test.
Okay. I'll just quickly go to Dr. Rahul. Dr. Rahul, you said you are using a kind of protocol in your hospital where you triage these patients, and then can you just shed light on that?
Yeah, actually, you can see on the screen. First of all, what we are doing in Ashwini in Mumbai is that we are doing a two-stage triage in the ER also. Before the patient comes to ER, at the entrance of the hospital, he is screened for any signs or symptoms of flu. So if he's showing signs or symptoms of flu, he's directed to the flu clinic. He doesn't go to the ER. We have set up a flu clinic. And only if he's not showing signs of flu, then only he comes to the ER. So in a way, we have actually tried to segregate at the gate only about the patients which might be suspected COVID positive. Now, all those who give signs of fever or flu are directed to the flu clinic, which is manned by the doctors and the healthcare providers in full PPEs, including the N95 mask. That is what we are doing in a flu clinics. And here you can see in a categorization. The problem is now, as you said, that any patient, let's say, who comes for any emergency, if he is falling in the green labels, as of now, till the ICMR or the Government of India admits that the community transmission is there, we cannot give PPE for surgery on the patients who are in the green zone. But definitely red zone patient, if he is operated, goes to the OT, should the surgical team has to don the full PPE, including the N95 mask. Now the doubt area is the amber colored yellow color. So now the recommendation is that even the yellow color, if the patient is going for surgery, should be done in a COVID OT and not in the normal OT. Since the community transmission is definitely happening in the hotspots, COVID hotspots.
Okay, Dr. Rahul, it's very impressive that you want to rationalize the PP and you clearly triage and till the community transmission is officially announced, you are not going to go with universal PP precaution. That's okay.
Actually, the problem is that the number of PPE which each hospital has is very limited. That's why we have had these two triage levels to impart additional safety for the clinicians.
Now I go to Dr. Sanjith. Dr. Sanjith, thing is that the two categories. One is COVID positive symptoms. The other is asymptomatic patients of COVID. But in between this, there are certain category of patients who say that they have traveled, but there is no cough, breathlessness, or fever. But they got sneezing, they got sore throat, they got running nose, body ache, myalgia. They might come with abdominal pain, diarrhea, nausea, vomiting. So all these symptoms have been reported to be associated with COVID. So how to go about these patients who doesn't fall under either category? Where do you admit them? You admit them in a clean area or in the non-clean contaminated area? So how do you go about with these patients?
So we first decide, we try to not take these patients in the first place. Our entire system is completely stretched because of these because of the nurses and the doctors being put into the ICUs, and they are no longer working with us in the general side, and we are also stretched working around the clock for these. So most of them we try to send them home, and we tell them to report to us with if they have fever, cough, or breathlessness. That's what we tell them. If they have anything, if they can manage this at home, very well manage it at home, and we tell them isolation precautions at home. Even if he has no symptoms, even if he doesn't have fever, cough, or breathlessness, any of these symptoms, we tell them to sit at home, isolate themselves, and call us if you have a continuation of the system.
Dr. Sanjith, I'm not talking about COVID. I'm talking about this patient present with, for example, severe abdominal pain associated with diarrhea, vomiting. You cannot just send them home. We need to investigate them.
So those
what
patients,
I'm asking
you, so what we do is we have completely floored our hospital. We have one floor dedicated completely to COVID, a separate lift, a separate system, a separate number of doctors going onto that place, separate nurse. Everything is separate there. Even the entry is separate. Whereas The general is completely trashed into a separate floor. Both the floors are separated by 4 floors. So these patients who are completely doesn't look like COVID at all. These are those patients who are triaged into that ward, and we've got seniors located in that ward who are specifically dedicated to that. They do not go anywhere. They don't even talk to us. The people who are managing COVID, they don't even talk to us. It's that strict. So those people come from a different entry. It's like a hospital in a hospital. That's how we work. And the complete duties are completely different for these kind of people. Yeah.
Okay, I'll go to Dr. Subra. Dr. Subra, when these patients presenting with, say, a stroke or myocardial infarction or chest pain or some other medical issues, but they have non-specific, not so COVID symptoms like sore throat, sneezing, running nose, body ache, kind of diarrhea, vomiting, because there are instances where cases have been reported, patient presented with chest pain, and ultimately they found out to be COVID-related myocarditis and things like that. And there are case reports coming saying that patient presented with encephalopathy, and they were turned out to be COVID patients. So when the patients come with such symptoms, where do you admit them? You admit them in the clean area and the clean ICU, or you admit them? How do you go about with these symptoms, which are not very specific of COVID, but symptoms like sore throat, running nose, sneezing, body ache, with a travel history or without a travel history, or the contact history?
I think what one of the other members have mentioned is actually the right way to do it. See, we need to triage these patients outside the hospital. This is basically the lesson we learned from the SARS epidemic, how Taiwan handled it. When they did allow the patients to come directly into the ER, they had huge number of patients and healthcare workers getting SARS. So what they did was they moved outside. They had something called a traffic management system. So everybody who comes in, before they enter the building, they are triaged and they are looked at. If you have a fever or plus minus a respiratory symptom, meaning respiratory symptom plus minus a fever, it doesn't matter what you have, they are triaged outside. If you don't have any of that, then only you're allowed in. And with that itself, they cut the transmission to healthcare workers and cross-contamination to other patients by a huge number. The number differences were 166 healthcare workers before this and 2 after. So huge differences. But the point is this, we need to start doing things like that. So if anybody has any respiratory symptoms, it doesn't matter what they came with, we'll have to consider the possibility of COVID in those patients. And the point is, if they have other systems involved, generally speaking, their involvement of the lung tends to be a little more than what is clinically suspected. But the patient may not be symptomatic enough for us to see it. This is where imaging can help us. I think we need to start doing more of either HRCTs of the lung or ultrasound of the lung, for us to identify a few more of these so that we can have more confidence that it's unlikely we do this. The reason, again, I'll say this again, if they don't have consolidation of the lung or changes on the lung parenchyma, even if they're shedding virus, their levels tend to be very, very low. So hopefully, at least it's not a huge contamination. It's not a perfect answer. But going forward, what will happen is that we are not going to be able to manage any of this. And we are probably going to have all patients going into the COVID area. And that's going to be even more difficult. But my point is, at this point, we'll have to consider that if anybody has respiratory symptoms, in addition to whatever they came with, we'll have to screen for the possibility of COVID and go forward from there.
Okay. So even if they present with non-specific symptoms, we have to possibly screen them either with a radiology or a lung ultrasound, and then we decide whether to do a test or not. And Dr. Sanjith, Dr. Girija wanted to know, now, how do you sanitize your CT room after a COVID suspect when you take a patient with COVID suspect?
Our entire machinery is now geared in sanitizing every time. What is happening is, the moment we have a patient that goes into a CT scan, we are suspecting as COVID. Once the CT scanner is over, we have a separate room where this patient is kept. And the CT scan is shut completely down for the next 1.5 hours. Actually, the time period has to be 40-45 minutes. But in case of concerns, we've made it 1.5 hours. So it's very sad to switch off the CT for 1.5 hours. And then subsequently, we get the infection control team to get in. They use the 1% sodium hypochlorite, half 30 cc's in 100 ml. They make it that way. And they clean first dam dusting, then they clean the entire place, and then they fog it. I mean, they also fog it. and after fogging, open up the area after 30 minutes. So it's a total event of around 2.5 hours that goes in after a CT scan. It's easy to, I have also put this in the protocol that every patient that comes in, we are actually getting a CT scan. As just Subra said, CTs are much more sensitive than the PCRs. So we are actually getting CT scans, and then we are taking the patient, because we're kind of a little bit petrified on patients that are coming into our ICUs. So yes, CT scans, this is how we are sanitizing them. Yes.
Okay, so you mean to say with the non-specific symptoms, if you have a doubt, go for radiology. And
Yes.
if there is no specific radiology findings, then you can admit them in the normal clean areas. Otherwise, they need to be treated as a suspect, and we have to do further testing, and they have to be isolated.
Yeah.
Okay, Dr. So now I'm coming to other questions. So many of our panelists and many healthcare workers now are routinely taking hydroxychloroquine as a prophylaxis. After this ICMR task force came up with the recommendation that any patient, any healthcare worker who's dealing with the COVID patient should take, means they recommended that they can take hydroxychloroquine prophylaxis. I'll go to Dr. Manish there. Dr. Manish, have you taken?
Yes, I have.
Okay, why did you take?
See, this is not a time to look for evidence. Evidence will come later on. They may show that it was useful. They may show that it was not. So we do not know if chloroquine is useful or not. Then to be on safer side, because it is not a very unsafe drug. It is actually a safe drug in the dose that it is prescribed for prophylaxis purpose. So that I thought it is better to take rather than wait for the evidence.
So with this dose of hydroxychloroquine, there are some scary WhatsApp forwards which are being spread saying that a few doctors took and they landed up in sudden cardiac arrest and things like that. But it has been proven to be safe for a long period of time in rheumatoid arthritis and all those case scenarios.
Yeah, and malaria prophylaxis and so many other things. It is a routine part of ortho practice and rheumatology practice.
So your hospital is having a policy of giving hydroxychloroquine prophylaxis to all the healthcare workers who wants to take?
No.
Or they have a restricted policy?
No, there is no policy by the hospital itself, but most of the people who are taking care of patients, they have taken themselves.
Okay. I'll go to Dr. Prasanna for this. Dr. Prasanna, what's your take on this?
Yeah, initially I was very for taking it. Then, in fact, I searched in many of the pharmacies here, but all over Tamil Nadu, not a single tablet of hydroxychloroquine was available. Most of the patients, the moment they got the WhatsApp forward, they consumed it. So, as far as our discussion, we had a great discussion with all our intensivist physicians and our team. So, the evidence is very weak to say that it protects anything. So there are some small studies. It is very difficult to conclusively say. If you think it is going to benefit you, you can try. But there is no, since the ICMR has said you can follow the guidelines and you can take it, particularly at least for those people who are working in a high viral load areas like ICU, who are primarily going to treat the patient. But as far as the other areas like where particularly in the ICU where they are going to intubate, and the patient is coughing, bucking, that was the situation. As far as the OT is concerned, if you are working in a COVID OT with full PPE for most of the cases, I don't think it is needed. You can safely negotiate it.
Dr. Ajay, what is your protocol? Means, are you actively promoting that? Or?
Sir, our institute is following the ICMR policy, at least for category A workers. So we are all anesthesiologists are category A workers. So they have given us for one course like 400 milligrams BD and 400 after that weekly. So we are all taking that as of now. And they make us sign a checklist prior to this when they are giving us the drugs. They ask us a questionnaire like whether we have porphyria or G6PD deficiency or anything, which is a contraindication for this.
Okay.
And pregnancy and all those things.
I'll go to Dr. Subra and ask him, Dr. Subra, why yes, why no hydroxychloroquine?
Let's look at the data on this. There was a very nice article which was published in Antiviral Therapy, looking at the data on chloroquine and hydroxychloroquine in prophylaxis. See, the theory is chloroquine and hydroxychloroquine change the pH of the lysosome, which is the portal of entry for almost all viruses, and therefore infect the cell. And we have had this fascination with chloroquine and hydroxychloroquine for a very long time. That's why it was in Harrison in the 9th edition. And in every edition after that, it's not been there. The question is, why is it not there in every other edition? Because they started doing testing on this. In vitro, it seems to be brilliant. So they started testing. They did a nice randomized control trial in influenza. Did not work. They tried a nice randomized control trial in dengue. Did not work. They tried it for Ebola. Did not work. They did it for chikungunya. It made it worse. Then we have to ask ourselves, is there a difference between in vitro and in vivo? For chloroquine and hydroxychloroquine, there appears to be a difference between in vitro and in vivo. That's number one. The second thing is, the dose that has been proposed by the ICMR has been based on the study which has been submitted to clinicaltrials.gov from the University of Minnesota. That is the only study which is looking at this weekly dose. There are about 10 to 12 other studies looking at pre-exposure and post-exposure prophylaxis. All of them are using doses between 200 to 600 milligrams once daily. Very creepy doses of 600 milligrams once daily. Most of them are using very high doses, 400 to 600 once daily. So as you can see, there is a huge spread. And the University of Minnesota is the only study which has not even recruited a single person. Not one person has been recruited so far. And they have only submitted as a protocol. All the other studies are being done with much higher doses. So ICMR has randomly cherry-picked something and said this is a brilliant idea. First, there is no data. Second, there is data to say that it could be making things worse based on prior studies. And third, it's not an innocent drug as people would make you believe. The problem is, remember, young people develop COVID, they are more likely to develop things like myocarditis. And when you develop myocarditis, the last drug you want to have on board is a long half-life drug like chloroquine and hydroxychloroquine, which will increase the risk of cardiac arrhythmias, which will kill the person. So I think it's a little dangerous. In the Infectious Disease Society, we've had long discussions about it. And our position on this is that this is not well thought out, and it's probably a poor strategy. None of us are taking it. But of course, if people want to take it, in my hospital, we are giving it to them after doing the documentation. But we tell them that there is absolutely no data to suggest it. And in fact, every scientific editorial that's come out in the last 2 weeks have all been critical of this move.
Okay. Dr. Sanjith, what is your take on this?
Right. So as Dr. Subra clearly put it, there is really no evidence to take HCQS. And in fact, this drug repositioning that we call repositioning or because low cost and maybe faster approvals and things like that makes you take even B complex. It's like B complex. It's not going to do anything to you. And that with that kind of a dose, I don't think it will do anything. As you rightly put it, why to take the significant side effects? There is a significant proportion of patients who come to the ICU with myocardial problems, and putting this HCQS inside doesn't make any sense. So not only that, when you have Ryle's tubes, even for treatment purposes, it becomes very, very difficult. So it's not, there is no evidence, and probably we should not use it, is what I don't know why ICMR did it. Thank you.
Okay. All right. So now moving on to the OT from here, I'll go to Dr. Prasanna. Dr. Prasanna, there are a lot of guidelines which suggest that at this pandemic, during these times, we need to postpone elective surgeries. So should we postpone all elective surgeries? How long we can postpone? Is there a time limit? And there are some surgeries which can be postponed but cannot be denied. Maybe 1 week, 2 weeks we can postpone. There might be some tumor surgeries, or the patient might be losing vision because surgery is not done, or patient can develop rather a neurological deficit. So how long to postpone this elective list? And what is the solution for that? How should we proceed with that? Yeah.
See, when we talk of this elective surgery, we can say either it is a cancer or non-cancer surgery. Okay. Cancer surgery, definitely we need to certify and do them as early as possible. Non-cancer surgeries, elective list can be postponed. There is no doubt. So there are two aspects to it. One is you are looking at the patient angle, how it is going to happen. Second one is you are looking at the resource angle. If you look at the resource angle, if you continue to do the elective cases similarly what you were doing before, then you may end up in a situation like you have flurry of patients who come in a 15 days time and you don't have any sterilium or even the gloves left in the hospital. So that's one of the issues there. Second one is the issue of the asymptomatic carriers. If you are really worried and if your residents and the healthcare providers, if they feel we need PPEs, so then if you want to use the PPEs for those elective surgeries, then any airway interventions, like most of our senior residents were telling, any airway intervention is there, we need a PPE. If you go by guidelines, it is not. If you go by the fear, yes, they want it. Then these are the situations when better to defer, because when a true COVID positive patient comes, you don't have. So most of the developed nations, what they are feeling now is the lack of most of the PPE and availability, thus increased transmission to the healthcare providers. So if you go by that, so it is better to defer the surgeries, most of the surgeries which can be postponed. And even in the onco surgeries, like cancer surgeries, if you have an alternative available, like a chemotherapy for a few days or a radiotherapy for a month, and then to take, even that can be stratified according to the each patient. As far as the emergency surgery is concerned, if it is a need to do urgently, then it has to be done.
No, emergency life-saving, limb-saving surgery is an entirely different thing. But what about some essential surgeries which have to be taken, which we cannot delay much? I'll go to Dr. Manish. If you take such a patient for essential surgery, for example, if patient is losing vision or patient has got a cardiac, got a deficit, so we have to do the surgery. So when you're doing the surgery, what are the precautions you are following? You are taking precautions as if the patient is COVID positive or the patient could be COVID, or you are doing only with the general precautions what we routinely do? Dr. Manish.
Yeah. Firstly, as Dr. Prasanna said, we have stopped taking absolute elective cases like spine cases, spine fusions, and all those cases. In cranial cases also, the cases which can be deferred for a couple of months, we are not doing them right now. But we anticipate that this problem will continue till maybe a couple of months or at least 4 to 6 weeks. So that the surgeries which have to be done in this time period, we are taking those patients. Then for preparation part, if the patient has absolutely no history of COVID or no travel history, then we are taking routine precautions more seriously. Like we are using N95 masks for all these patients. We are wearing gowns and
No, for all the patients, you are using N95?
Yes, all the patients which we are intubating, we are using N95 masks because hospital is providing at this point of time to all the people who are intubating patients in the OT.
Okay,
and
so
goggles and basic
even they are asymptomatic for COVID, you are using
yes,
N95
yes.
for
all the patients, yes.
Okay, so only the anesthesia team or even the surgeons are wearing?
No, only anesthesia team is getting. The people who are intubating, they are getting the masks. Not
But
otherwise.
there are reports which say that even drilling and other things can produce aerosols which can contain virus, and so especially
Yes,
the
so
orthopedic drilling and especially the skull base drilling of skull base can produce a lot of aerosol. Of course, the endonasal surgeries are out because there is a report from China which said that almost 20 odd healthcare providers in the same operating room got infected after an endonasal surgery. So even pituitaries, they're contemplating or alternative techniques like transcranial if it's absolutely essential. So
that is true.
don't you think that if that also amounts to aerosol generating procedure and everybody should wear proper PPEs, or no? What is your
You see, craniotomy, most of the times when they do craniotomy, they do not touch the areas where usually the virus are. And pituitaries, you are right that we are not doing endonasal procedures anymore. At least no patient has come for like presented as an emergency in these many days, so that we even did not have to cancel the case also. But for routine cranial cases like ICH or aneurysm surgeries, or I think that in those surgeries there is the bone dust. I don't know whether bone dust itself contains virus or not, because it is speculative more than evidence based.
Okay, I'll ask Dr. Subra. Dr. Subra, does drilling work, the bone work, the fracture work, all those things generate viruses? Is that constitute a aerosol generating procedure? Should surgical team also wear proper precautions, at least in positive patients? So what is your take on that? Because there are guidelines which say that even in positive patients, once the surgical team enters the operating room after the aerosol generating procedure, namely the intubation, everything is over, after 20 minutes of that, they need not wear N95 at all. They can just go ahead with only with the surgical mask. That is alone is enough. That's what some of the European guidelines are stating. So what is your take on this?
But Dr. Ponniah, you have to read the European guidelines a little carefully, because they talk about having a negative pressure theatre room with very good air exchanges. So unless your theatre is ready for that, that will not apply. See, most of our theatres are positive pressure because we are trying to push the air out of the theatre, from the patient, away from the patient, towards and out the door. And here it's the other way around. We don't want the air to come from the patient to us. So it's upside down. So that's a bit of a problem. So please understand, when the Europeans say that, they can easily switch the theatre from a positive pressure to a negative pressure. You know what? We can actually do that. If you talk to engineering control, they'll tell you it's not very difficult. But that basically means you are increasing the infection rate to the patient. That's a potential concern. But if you believe that the risk outweighs the benefit, meaning the safety issue is significant, then we should do that. So that's the first thing. The second thing is, you're right. Yes, if we are careful about the aerosol generation for at least a significant period of time, after that the viral load comes down significantly, and therefore the risk is very low. Granted, but we also need to look at how the exhaust air goes out from all these patients. So if we have at least some form of scavenging, that will be a little reassuring. Not that it probably contributes a heck of a lot, but that's a theoretical concern. The third thing is, it's also about the amount of drilling we're going to do. If I'm just going to put a small burr hole, the risk may not be so much. But I'm more actually worried about orthopedic surgeries where they're going to go reaming and stuff like that. So when you have a polytrauma, you guys may be involved as part of a polytrauma situation. And if you have an orthopedic colleague coming in and start reaming a finger or something like that, that's a whole different ballgame, because the amount of viremia that can happen and the amount of virus that can be nebulized is potentially quite high. I think this is a very difficult situation, because in these kind of patients, even if you do a CT of the chest, the CT of the chest could look abnormal for many, many reasons, not just COVID. So I don't think a CT chest or anything like that will be accurate. If it's normal, that's great. But being abnormal does not necessarily tell you it is COVID, and therefore you have to be careful. To drive a long story short, I will put it like this. Yes, during the time of intubation, you want limited people in the theatre. Yes, you want to have a negative pressure room. Yes, you want the anesthetist to wear an N95. Yes, you want to reduce drilling and insufflation and things like that. Yes, you want to shorten operative time and get the things done as quickly as possible. Yes, you want to screen your patients if it's possible. And if this is not possible, then wearing full gear is the option. My concern is we are going to run out of gear very quickly. And it's really, really weighing on my mind. Every day that I go in, I have to ask myself this: how many days can I support our PPE use? And it's really worrying for me, because the N95 is probably the first thing that's going to run out. And that is really scaring the daylights out of me. But we have already developed protocols on reusing the N95 based on some of the studies that we have seen. And I think that will probably have to be the way to go. We have to be very careful about N95 so that we can keep reusing it in a safe manner.
Okay, regarding that, viewer one of us also asking about recycling N95 masks. But is it the right time to do, Dr. Subra? Because we have not exhausted our resources. Should we jump in for that as if we have exhausted all our N95 masks? Is it the right time to recycle that? And how we can be sure that that is going to be absolutely protective when there are no testing standards of recycled N95?
Right. That's a good thought. See, here's my answer to that. The problem is that every country which said this landed up in trouble with N95. Italy, Spain, UK, US, everybody's in trouble. Nobody has N95s, and it's become a problem. And manufacturing is an issue, because most of the raw materials have to come from China. China was nice enough to start sending kits for money, of course, kits and masks and whatnot to the Western world. Guess what happened? They found all of it so substandard that they were useless. They threw it back at China. So right now, if you want to get any kind of PPE gear, you have to get it from China. And I'll tell you, somebody put up a nice meme saying this is the longest that anything from China has lasted, COVID virus. The COVID virus from China has lasted much better than anything else coming out of China. And please don't be holding your breath saying you're going to get resources from China. Those Chinese resources will stand nothing against COVID. My sincere advice is, please start rationing your PPEs. I don't think you're going to have help coming anytime soon. And here's the problem. The government will make us look like heroes. And the minute trouble starts, we'll be made to look like villains. And that's what really worries me. In Italy and Spain and in US, people are working without appropriate PPE also. I am petrified of that problem. I think we should start being careful about PPEs today. Because if we start using it generously, there will be a time when we'll end up becoming beggars. And I really don't want to see any of my colleagues getting into trouble. Please. I can't afford to have a sick colleague. I don't want to see a sick colleague. That's going to be on my conscience.
Dr. Rahul, you have a point here.
Yeah, actually, I can't agree with Dr. Subramaniyan more on this aspect. I would definitely like to use the N95 for all my intubations. In fact, if you read the Chinese experience published in the anesthesiology special issue, they've also said that, and which we are doing is we do a secondary triage once the patient, just before the patient enters the OT. We again look for the patient's temperature. We check for any signs or symptoms of a flu or COVID-like symptoms. So if the patient might be asymptomatic at the time of admission, but he might develop any of the 5 or 6 symptoms, then we treat him as a COVID suspect and proceed with the full PPE. If still in the secondary triage he doesn't fulfill any of the signs or symptoms of a COVID positive, then we do it as a normal emergency. But knowing fully well, as Dr. Sanjith has said, he is also in the hotbed of COVID like me in Mumbai. Community transmission, though the government might admit it at a later stage, has already started. So we take slight extra precautions. Now, I am not using N95. What we are using is that surgical mask with a visor, and we have made an in-house box to prevent the aerosol dispersion once during the intubations. So one has to be practical. I would like to have N95 mask for all my intubations. But if in the secondary triage, if we find that the patient is not showing any symptoms or signs of COVID, then we go ahead as a normal emergency procedure. Yeah, if he or she shows any sign, then we go ahead with the full PPE.
Yeah, I'll go to Dr. Sanjith. Dr. Sanjith, you are in the COVID belt. Are you reusing N95?
Oh my God. I've not thought about it, but I'd like to learn about it because, as Dr. Subra clearly and everybody is mentioning, there is an absolute dearth of PPE at the moment. At the moment also, I myself am searching for PPE. The approximate amount of PPE that is required per day in my ICU presently is somewhere around 70. That is the amount of PPE we are requiring per day. Each PPE is costing somewhere between 1,200 to 1,500 rupees. So it's like a massive amount of PPEs that are required, and everybody is petrified. Without PPE, nobody gets in. That is an issue that is happening here. That is a big issue that is happening here. Coming to surgery, that is the reason that if we can delay surgery as much as possible, that is the most important thing I think we should think of. And I don't think we should be really concerned with that patient. We should be concerned of our own healthcare workers, because many of us may be asymptomatic carriers. We are standing with them. We are going to OPDs. We are having open hospitals. We have patients coming to you. You might be carrying that. So the person and you're in prolonged close contact with your nurse, with your doctor, with the assistant surgeon, with everyone for a long period of time. So he sneezes, he shouts, he removes his mask. It's going to be an issue here. So I think if you suspect COVID, you go all out. Most importantly, when I say PPE, it means gown, N95 and eye shield. An eye mask has to be there, especially when you're going to intubate your patients for surgery. It can't be just the N95. And Subra, I'd like to know how do you recycle this? Yeah, I'm already running out of it.
Okay, I'll ask Subra as well. How do you recycle N95s if the necessity arises?
Oh, we've already started doing that. So there are a couple of ways of doing this. Each one has a different benefit. There's actually a paper and there's actually guidelines on the CDC website as well as to what you can do. They've done everything from putting it inside a microwave to putting it inside an ordinary oven and things like that. My own way of doing it is a little different. Let me put it like this. See, no surface can hold the coronavirus for more than 48 hours. If you look at all the studies that have been done, no surface holster for more than 48 hours. So what we are doing it is, for all our anesthetists and intensivists, we are going to give them 3 N95 masks and have their names written on it. Let us say, as an anesthetist, today use an N95 mask and you use it all of today. At the end of the day, you please take it off and give it to us. What we do is you put it in a clear, transparent bag and then leave it out in the sunshine for the next 48 hours. So we get 2 things. You know, sunlight kills viruses and you know, time kills viruses. So we use both of these and reduce the risk of the virus still being present. Because one, we know after 48 hours, no surface is hospital enough to hold the virus. And second, with the baking sun, honestly, why are we wasting that? Let's use that to our benefit is my thought. So that's what we have done in a clear, transparent bag so that, you know, nothing falls on it and things like that. And we are starting to do that because I don't think you can have a evidence base on this. There are other options if you're going for evidence base. For example, putting it in a microwave, putting it in an ordinary oven and all that. The problem with that is that in that, the metal part over here starts getting discolored. The ties start going a little problematic and things like that.
Okay. So, you know, to prevent the non-availability at a later stage when we'll be in real crunch, the ideas have already started, but I'm not sure of, you know, of the quality of the recycled PPE, how to trust on that and go about it. The time has to say, but anyway, it has been already started and there is a way to do that. I'll go to Dr. Nitin. Dr. Nitin, because of this COVID, for essential surgeries, are we trying to modify our technique? For example, want to avoid aerosol generation, so instead of GA, you opt for regional anesthesia or nerve blocks, or surgical technique itself, instead of transnasal, they go for transcranial and things like that, or such things started happening, or what's your experience in this?
Yeah, definitely. I think the surgical technique has to be modified. We don't do laparoscopic surgeries now. We don't do arthroscopic surgeries. We don't do nasal endoscopies. We don't do transphenoidals. So these are some of the surgical aspects, and the surgeons have also gone to a consensus about this, and they say that they don't want to do this. So they are all doing open surgeries now. And so this is about the surgical modifications. And we need to stratify. So we need to stratify our patients, how risky the patients are, and then we need to use our PPs. So that is going to be the way ahead. And we need to, currently we are doing mostly, wherever regionals are possible, do regionals, do spinal or do epidurals for cranial surgeries or other surgeries. But the second thing is use hoods or use transparent sheets to prevent aerosol transmission. So I think all of this we have, learned our lessons how to limit the aerosol transmission. And also I think these LMAs and triagels, I think these have to be done away with because they are not considered safe now. So there are so many techniques that we can use as anesthetists in the OT to reduce aerosol transmission. Minimizing the OT staff and minimizing the number of people in the theater is also one thing. And then how you choose to run your OT. So run limited OTs, give space between OTs, and then you need to look at your staffing, and there are various things that you need to look at.
Okay. I'll go to Dr. Sanjith. He has a point. Yeah, Dr. Sanjith.
So, the real thing is, first thing is the senior most anesthetist has to take the job here. You cannot leave it in the hands of a junior. You cannot leave it at the hands of anyone else. It has to be the senior most. It has to be one attempt. It can't be more than one attempt. There cannot be pre-oxygenation. It is impossible to pre-oxygenate if you suspect a COVID. We shouldn't pre-oxygenate. If pre-oxygenation means you put a mask, the protocol that we've put is put a mask on the patient, a surgical mask, put an NRBM over him and let him breathe for say 5, 6 minutes, 7 minutes on his own. Then use atropine, let the secretions be minimum, keep the suction out of place. Keep the suction out of place, don't even use the suction. One attempt at intubation with all provisions, go inside, and that one attempt can be done probably only by a senior most anesthetist. It is very essential to quickly intubate, inflate the cuff, and attach the viral filter to the tube as quickly as possible so that we don't have multiple attempts and more amount of aerosolization for certain. More importantly, after you intubate, that laryngoscope, we are not using disposable. That needs to go into Sidex OPA. Unfortunately, we all have the habit of intubating and keeping it back onto the tray, which can be disastrous if it is suspect COVID. I mean, that should go into a plastic wrapper, a zipper wrapper, and that should go into Sidex OPA. That's how it should be done.
Okay. Another question from Dr. Manjunath. If we start admitting COVID patient, should we take non-COVID patient in the same hospital? Because from China and even in India, people have started creating COVID-only hospitals. So is that the way to go, or we can mix up both the patients in the same hospital, or is it enough that we isolate a particular ward or particular floor or particular ICU for COVID patients, and the rest of the patient can be treated safely in other areas? Dr. Subra, I need your opinion on this. Yeah.
That's a very difficult question. Let me put it like this. Practically speaking, that even if you have a non-COVID hospital, please understand you are going to have COVID patients coming in. Because the patient, when they come in serious, they are not going to know if there's COVID or not. They're just ambulance is going to rush them to the nearest hospital. And second, like all of you guys have mentioned, at the time of intubation, you don't know who's baking a COVID. So the COVID may happen either after the time of admission or after the surgery as well. So I think all hospitals have to be COVID ready. The problem with having COVID-only hospitals is that it's going to be very difficult to handle them all by themselves, because remember, COVID patients have a high risk of cardiac events. So you need to have a cardiologist available. They could have other system abnormalities. Remember, they could need dialysis because they are dialysis patients. Remember, most of these patients already have pre-existing medical conditions like diabetes, hypertension, heart disease, whatnot. So please understand, you're going to have specialists transferring through all these areas. So we need to have task force which can handle this area and that area. Some countries, what they have done is they have said our older caregivers and people who have chronic medical conditions probably should not be exposed to COVID patients, and therefore maybe they can handle the non-COVID patients. And the younger people and healthier people, because their risk is probably less, should be handling COVID. Again, there are ethical concerns to all of this. I don't know if it's feasible. Long story short, I think it's fine to have a COVID hospital, but even the non-COVID hospitals have to be ready. And please understand, if you look at the Johns Hopkins projections, at the peak, you may have up to 25 lakh hospital beds required. That's in the worst case scenario, 25 lakhs. And the best case scenario, at the peak, you need 11 lakh hospital beds. So we don't have that many beds, which basically means every hospital will become COVID hospital. So I think that's going to be inevitable in a country like India.
Okay. I'll go to Dr. Jana. Dr. Jana, welcome to the show. In this COVID era, it has been recommended, or it's at least sensible to use video laryngoscopy instead of conventional laryngoscopy, so that the anesthetist does not really go near the aerosol generating site. So what is your protocol? Has your protocol changed with video laryngoscopy in the emergency as well? I think we lost him. Dr. Sanjith, Nitin, you can answer this, yeah?
Yeah, I think video laryngoscopy has to be made mandatory for intubations. I think we need to procure more video laryngoscopes because this will minimize our risk. And this is one thing which I think everyone has to start following and procuring. And this is the time that we need more video laryngoscopes, definitely.
Okay, all right. So now that there are patients who develop fever, breathlessness, cough during their stay in the hospital. They might be admitted for some other procedures. They might be operated. They will be in the post-operative period or in the recovery phase. And when these patients develop such symptoms, should we suspect them as COVID in this condition, or we just treat them as a routine post-operative complication and we should proceed with a routine care? What is your opinion, Dr. Sanjith? Yeah.
Okay, so see, now here comes the definition. If you look at the March 17th guideline that came in from the government of India, They've said in a healthcare facility which treats COVID, if there is a sudden deterioration of event of any nature, you have to suspect it as COVID-19. Now, it is easy to suspect it, but the moment you put him in a ward of COVID-19, you're using a PPEs, you're putting him into an isolated facility. He can't talk to his people. The relatives are away from everything. It is very, very, very difficult to treat such patients inside and convince them that this could be COVID. But yes, this is what we are doing.
One more point is, he turns out to be negative for COVID, or at the end of the day, or after a few weeks, he was found to be non-COVID. Then we are subject him to a risk of being exposed to a COVID patient as well in the COVID area. So yes, that's also a concern.
Absolutely. So we've had this problem, and in fact, we've had patients shouting and screaming at us that you put it into a COVID when I'm not COVID, and we're all roaming around with all those PPEs, and they keep telling us, what if I get it from the other patient and things like that. So we've developed a protocol where we keep our suspect COVID.
I think I lost him. Dr. Subra, can you answer that?
Yeah, this is pretty difficult because he's absolutely right. Because when you have a patient where COVID is a possibility, to shift them to a COVID area is basically causing all kinds of hell. We're going to have patients and their relatives starting to throw stones at us. And it is not unheard of, please mind you. They're already having events of abuses and attacks on healthcare workers for presumed problems. So this is a serious issue. The government is very generous in its guidelines. They will say, do this, do that. They are not the ones who are going to be standing there and do all this, doing all this. Just like they said, give 995 to everybody, including the dog and the campus. They are not going to come and stand next to us if there is a problem. But they are right. In that, we have to consider it's a possible COVID. So my solution is this. So if you have a COVID positive patient, as long as you can have them in a single room, if you're going to ventilate them in a single room, first understand the engineering controls in your own hospital. That is absolutely key. The point is, air handling systems make a difference. If you have a patient on a ventilator, you're talking about airborne transmission. So talk to your engineering and ask them, show me the airflow patterns, show me the air handling units, show me the pressure gradients. That's absolutely key. So if you have an ICU and if you have an isolation in that, that's your first port of call. If you don't want to shift them to the COVID area, your first port of call is move them into the isolation, but you have to make sure that the isolation's air handling unit is separate, absolutely clear, separate from the rest of the ICU. And second, you want to have a negative pressure gradient into that room. See, think of your TB patients. Where would you put them? Same place. If you have a room like that, that could be a halfway house where you can have only one nurse stationed there taking care of the patient in full gear so that the patient doesn't feel that they've been shunted to the COVID area, but at the same time, all COVID-related precautions are being taken for that one patient. And the idea is you need to test and turn it around as quickly as possible, because the faster you turn it around, the quicker you can release the patient from that area, and that room now becomes available for a subsequent event if it happens so. But that room should never be given for routine COVID care, because that is your fallback option when things go south on any of your patients and you don't know if it's COVID. Just a thought.
Okay. And adding to this, you are talking about stressing about the engineering control. Very, very important. Apart from our PPEs, nobody talks a lot about that, our engineering controls, negative pressure rooms, and
right.
Because we all know each hospital has its own limitations. We don't have so many negative pressure rooms. We don't have so many typical that isolating facilities with separate air handling rooms like that. What I want to ask is there a role for portable HEPA filters in this kind of scenario? Will that work?
Very quickly, not very convinced. See, here's the problem. Portable HEPA filters will reduce the load, but you need a heck of a lot of HEPA filtration for you to be able to sterilize a problem. And second, you have a patient who's continuously generating aerosol and therefore contaminating the environment. So unless you have negative pressure, you can't have a situation where none of the viruses will escape the room. Remember, when you're on a ventilator, the exhaust from the ventilator is coming under pressure. So it's being ejected out. So you can have a draft of the ejected air which has the viruses moving out of that particular room in the ICU into the corridor and therefore to other patients. So therefore there is a risk. So without a negative pressure, having just a portable HEPA filter is not going to add. See, to me, it's very simple. If I can vent the air very high up, away from everybody else, that is the most acceptable scenario. Hopefully, given the sunlight and the heat, the virus will die. I think that is a better way. I don't worry too much about portable HEPA filters. Portable HEPA filters are only a possible option if your room is airlocked and you really don't have a choice and you're trying to reduce the bioburden. I would look at it as a last option, not the upfront option.
Okay. Dr. Rahul, you have a point, yeah?
Yeah, I'll just start with a small history. Beginning of this week, we had given anesthesia for a 82-year-old patient who had come with stent thrombosis. Now, as I said that we had done a secondary triage before we took him to the cath lab. So he had none of the COVID symptoms. So we didn't use the N95 mask. We used the normal surgical mask with a visor. Then we donned in the proper gloves, the fluid resistant gown, like we do for any other case. And same with the resident and the cardiologist and the entire team. Now, 2 days later, this 82-year-old patient developed patch in the right upper lobe. So again, there was a lot of panic, but we got him tested for COVID as per the guidelines. Any admitted patient who develops a pneumotic patch has to be tested for COVID. He came COVID negative. So we all heaved a sigh of relief. Now, what we had done was, from the secondary triage throughout the peri-op period, even during the transfer, we did not doff that our surgical gown, gloves, as well as the 3M mask with the visor. Same now in the ICU, we have instructed all the ICU nursing staff to be wearing gloves and the mask, properly wearing mask all the time. So we were not very afraid if this had come at COVID positive also. We had taken all due precautions. So I want to highlight that it's very difficult saying you cannot have an N95 mask from the beginning only. We had done a secondary triage, but patient had a patch.
Okay.
So I want to stress on the adequate training of your staff for taking precautions at all times. And precautions are they should know how to wear the normal surgical masks properly. They should don gloves at all times before coming in contact with any patient. And they should wear at least one surgical gown which covers the body. If they can wear a hood, nothing like it, we're trying to have a hood also. But N95 mask is not required for every procedure.
Okay, right. I'll go to Dr. Dr. Ajay. Ajay, Dr. Ankur wanted to know, is there a difference between TIVA and inhalation technique in COVID positive or suspected patient? Because there are some anecdotal reports and some discussions happening which say that inhalation could be dangerous in these patients.
Actually, if the patient is not having an obvious lung lesion, which is going to prevent the inhalational agent from getting into the bloodstream and maintaining the adequate depth of anesthesia, I don't think there is much difference between TIVA or inhalation, because it is not, as long as we maintain the depth of anesthesia, it is not going to make much difference. Only thing is, we cannot go with our conventional MAC value where, especially if the patient is having a very bad lung. I don't think, and already these patients are hypoxic when this HPV will be lost in this patient. So I don't think it is going to make much of a difference, TIVA or inhalation, unless there is obvious this thing. And I would like to add a couple of more points to what Rahul sir has told. Exactly like what we said, we should have a secondary triage of patients before taking into theater, or like if you are going to go for intubation or any such procedures. And even our institute, we have developed protocols for this triaging as well as donning of PPE. And the risk of benefit should always go for the healthcare worker. It is not for the patient. So even if it is a minimal doubt is there, we should go for that. And If it is it possible to share this slide here?
Yeah, please, yeah. I'll just show the slide. Yes,
Yeah.
yeah.
So yeah, this is the one which we have developed for our institute. So we have a score-based system where, in addition to the additional 7 points which the Ministry of Health has given, we have added the last 3 points. These are from CDC and NHS guidelines for Category A workers. So anybody who falls above the score of 2 is intermediate risk, 2 to 4 is intermediate, and more than 6 is high risk. And based on that, we have risk categorized and the PP which should be used in each of the scenarios. So if you can note, from intermediate risk onwards, it's full PP. And wherever there is an aerosol generating procedure in high risk as well as a proven COVID, we have to have a face shield, because that gives additional protection to the healthcare worker. And in addition to that, there's aerosol generating procedures like not only bone drilling, we also encounter QSA in neurosurgery. So QSA is also a proven aerosol generating procedure, as well as anyway endoscopy is out. And one more point which I would like to add is, in ICU settings, chest physiotherapy is being given. So that is also aerosol generating procedure. And some precautionary measures like already been discussed. We should ensure that minimal staff is there during intubation, and most of our theaters are positive pressure ventilation, so we have to turn it off during the procedure till 20 minutes post the last aerosol generating procedure. And also one more point I would like to add is, we have to wrap up our machine also, because these aerosols are going to go and settle in any surface, and we might go and touch it after the at a later stage. So the wrapping of the machine is also very important in this scenario. As well as we should not use any portable ventilators for transfer. It should be always with a dedicated ambu bag with a viral filter attached. And this is a checklist we have developed so that the team does not miss any point when they are uh, doing the case. What are the before the patient arrives, what all should be ready, and what is the pre-intubation checklist, what is the intubation and post-intubation, as well as the airway drug checklist and the extubation guide, and how to connect the HME filter and where to detach the mask and how it goes around. And another one point which I want to add here is the bag and mask hand technique. We are usually trained in the CE technique of mask holding, but in this scenario, it is a vice grip. As you can see here, this is what is been recommended by European as well as CDC guidelines, which reduces the aerosol propagation in our scenario. So this is how we should hold the mask in these situations. And in addition to video laryngoscopy, which has already been discussed, a plastic drape or a transparent cage, intubation cage, should be there in situ, so as to prevent the aerosol transmission and propagation into the OR room. So that's it in brief.
Okay. So thanks, Ajay, for your brief on that. So I think we are nearing our discussion. To wrap up the discussion, I'll just go with the question. See, we are suspecting a COVID patient. He's come for some other problem, or during the course of hospital stay, he developed a COVID symptom. We send a test and it is negative. So how to proceed in these patients? If you're suspecting clinically and the test is negative, still you isolate them, or you keep them in the clean area, or you repeat the test. So what should be the protocol, Dr. Subra?
So please understand that it depends on what sample you're taking. Most of the time, we're taking a nasopharyngeal swab. Oropharyngeal swab is actually the worst of the lot, because your positivity rate is probably at best 50%, maybe less. So oropharyngeal swabs are useless. Please don't take any samples from the mouth. Nasopharyngeal swab, the best way to do it is ideally one of these things into each nostril and set it off. Even with that, your pickup is possibly around 70%, in which case 30% of your COVID patients may not turn out positive even on the PCR. So that's a bit of a problem. There was a very nice publication which came in from China, where they said that they used the imaging as the gold standard. And when they went back later on and did a bronchoscopy, if the patient got intubated, and they did a PCR on that, many of the patients who they thought were COVID, based on radiology, in spite of a negative nasopharyngeal PCR, had a positive PCR on the ball. Now, doing a bronchoscopy is being reckless because it puts the healthcare provider at risk, and nobody can justify that kind of a risk. So I think we need a combination of both a PCR and some form of imaging. And like I said, I'm favoring the lung ultrasound above the CT for safety purposes and for the fact that, bagging a patient right through all these areas could be tricky. But if that's not an option, I think between a combination of CT of the chest, HRCT, you don't need contrast, a plain HRCT and a PCR, I think most cases will be identified correctly.
Okay, Dr. Ajay, your point, yeah.
I just want to add one point. In our institute, the radiology protocol, they have included a portable X-ray, which could be used in this areas where these patients are coming in, and also a portable ultrasound. Because again, the CT scan is tricky because air conditioning system, which is there in the radiology, most places it will be a shared air conditioning system, which will be sharing the airspace with the MRI and other places. So to decontaminate an MRI is impossible. Like in this, we can't use a vaporizer, and it's very difficult to decontaminate an MRI. So the radiology people are really scared of getting any patient into their complex. So they have given a option of ultrasound as well as a portable X-ray in these areas, and they have asked to manage only if it's a really low risk patient and like stroke, they just want to get a CT angio with a really low risk probability, they're ready to accept it into the CT area. And like I said, because the cleaning of the CT area itself is a time consuming, because they can't take the next case at least for 2.5 hours. And one more thing I just want to add is on the PPE. Our center, we have started reusing the PPE. We are using plasma sterilization. We are tagging, like how Dr. Subramaniyan said, we are just name tagging, and we are sending it for plasma, and we are getting it back. Because if we don't start now, there is no point waiting till the entire stock is exhausted and then start to trying to conserve it. From the first day itself, we should start conserving our PPE, because finally at the end of the day, we are going to face the heat, not the surgeons or anybody, because first we have to intubate, then only they all come in. So if we want to conserve our things, we should be very careful about it, and always conserve the PPE. And even steroid is being used now. It is, and CDC has come out with clear guidelines. They have said that once the sterilized N95 can be used in all patient care areas, except if you are going to get involved in an aerosol generating procedure, they say that you can consider a new N95. So only if the person who is just using causing an aerosol generating procedure can wear the new mask, and the rest of the people can just go ahead and reuse the N95, which they have already got it sterilized priorly with their name tags on. So this is what the CDC has come out with.
Okay, so a lot of things to discuss. I think we'll be having frequent sessions in the coming week. There are a lot of things like how to carefully utilize our resources. A lot of articles on splitting the ventilators. Why not to split the ventilators? And there are some innovations or rudimentary techniques of ventilating within ambu bag pumps. All those things are coming up in the market. So we'll discuss it about the actual COVID management and how to go about with that, the airway management, ventilation management, and the ICU management at a later stage. There are a lot of questions about that, also about the convalescent serum, plasma, all those stuffs, which creates a lot of interest among the people. But one thing is for sure, like I read recently in some tweet, most people are just behind what is the magic bullet or what is the magic drug which can treat COVID, which we are not going to get anytime in near future. One thing is that whatever the guidelines which are roaming around should put in block letters saying that there is no definitive drug treatment for COVID at present. Almost 80% of them get well with time. 10 to 15% of them require admission and oxygen. And the rest 5% of them need really critical care with ventilation, proning, maybe dialysis and other organ support, maybe ECMO in some patients. So this is where we are, and we'll be discussing
I would
that.
say this is just the situation. where Darwin's theory of the survival of the fittest is just being practiced in this world, because the only one who is fit is surviving. That's just a simple theory of Darwin.
Okay.
I think it's okay to say that on a closed conversation. As long as it's not mentioned outside, I think we'll be okay.
Okay. So with this, we'll conclude this session, and we'll be meeting tomorrow with another important topic, especially for anesthesiologists, which will be helpful about airway management in a COVID patient. So there are different innovations which are happening, how to prevent aerosols, including the aerosol box and techniques like that. So we'll be discussing that about video laryngoscopy and how safely to intubate such patients. So see you tomorrow at 7 o'clock in classroom. Stay tuned. I'll be shortly sharing the link with you. Thanks. I'll thank all the panelists, especially Dr. Subra, Dr. Sanjith, Dr. Rahul, Ajay, Prasanna, and Manish for coming and participating in the discussion. It was a very lively discussion. I hope everybody enjoyed that, and our viewers will be greatly benefited by this discussion. Thank you.
Thanks, Ponniah. Thanks, Ponniah, for calling me.
Thank you.